Well, thank you very much to each of our three speakers. And we're open for questions, and I think I'm going to take the prerogative of asking the first one to Eric and Lori, based on some of the work that Jody presented. When we think of competencies, it seems that in the medical profession, I'm used to thinking of a skill or a capability that's being measured, that on the four axes that you presented, Jody, would be, I guess, quality. And I think we haven't thought so much about complexity, consistency, and efficiency, the consistency being validity and reliability. Now, I'm a golfer, and I've been told the difference between an amateur and a professional is an amateur will practice until they get it right, and a professional will practice until they can't get it wrong. And if you think about that a minute, there's quite a bit of difference. And you could say, well, that's just the difference between a novice and an expert, but that's not necessarily correct. And so if we think of our competencies being measured simply along the line as can they do it, that doesn't mean that they will do it every time, and that they're reliable about doing it. They can do it in different areas of complexity and so on. So Eric, let me throw the question out to you first. Are you thinking along those dimensions as you're creating milestones?
Yeah, thanks for the question. The answer is absolutely yes. I think that there's a couple really important points here. One is, I think what you're alluding to is the importance of sampling because of the importance of context. We've learned, in assessment research over the last 15 years, how important context is on the judgments we make about somebody's abilities or competencies. And so, one of the ways to get around that is if you sample. And so you need to have robust samples, and that's why it's so important to embed assessment as an ongoing activity. I think that's really important. The other thing you alluded to with your golf analogy is that it's not enough just to simply practice. It has to be deliberate practice. And this has been most, I think, highlighted in medicine by Anders Ericsson's work on how people develop expertise. Part of our problem in medicine is we have what is often called circumstantial practice. I'm an internist. When I was going through training, it pretty much depended who came through the emergency room became my curricular experience. Instead of, okay, you need to take care of diabetes patients, let's make sure that you have a robust panel of diabetes patients you can take care of and continually practice, because each of them are going to be a little different and the context is going to be different. And so through the sample of multiple patients that's guided through, a framework that helps us, enhance your education, I think is really important. The other thing I just really highlight, getting to Jody's point, is how important assessor training is. That online training that she does is absolutely essential. The idea you simply hand somebody a form without some of training or understanding of what it is you're asking them to look for, I think is also really important.
Thanks, Eric. Lori, do you want to make any comments?
So because he didn't, I'll steal a line from one of Eric's slides, and that was the one about observe, observe, observe. And it really is the nature of thinking about thinking about assessment from a single isolated episode to a process that occurs over time. And I think about the level of complexity that our students see both in a changing healthcare system as well as in the kinds of patients they see. So for example, a faculty member who is preparing students to be family nurse practitioners. One of the goals I have as that faculty member, for example, would be that one of my graduates can provide care for a middle-aged individual who has chronic comorbid conditions, the big three. And in our current system, if we were to really be honest about what we do often in our current system in advanced practice nursing education, it's a strategy that a colleague of mine calls place and pray. So we place a student in a practice and we hope that they will be exposed to a significant number of patients who have chronic comorbid conditions. And then we hope that two other things will happen. One is that the preceptor will treat those patients according to current evidence. And the second is that the preceptor will be able to impart that knowledge in a way that it sticks with the learner. And there are some pretty hefty assumptions in that approach, that an ongoing robust plan of assessment allowing multiple assessors over multiple periods of time, facing students with multiple patients over time, takes out some of that variability.
Thanks. And my quality scholar work, Paul Batalden told us many years ago, although a commonly used strategy, hope is not a very good one. Any other questions from the committee or the planning committee? So I do have one question from the audience, so you probably know who you were. And you can stand, introduce yourself. Right behind you, you've got a microphone. Thank you.
Hi, I'm Judy Martin Holland, and I'm from the University of California, San Francisco. And so I'll let you read the question. I'll give a little
All right,
background
that'd be
if that
great.
helps.
As certification bodies change eligibility criteria, and as nurses approach and obtain education using various modalities, how do we know the influence education has on the value of individual certification, the credential, and on patient outcomes?
So I'm sort of hearkening back to both our discussion from the first panel this morning in terms of looking at credentialing and the value that it provides, or that we are assigning it, and wondering if education is additive, if education, what the relationship is, and if it's something that we should look at in tandem, or if we continue to look at that separately, how then it could feed back to those certification bodies that are looking at their eligibility for certification.
Thank you. Go ahead.
Now it's on? Maybe it doesn't want me to say this. Okay, so we recently had a study that actually looked at our licensure and looked at clinical performance instrument outcomes to see if there was a relationship. And in fact, they assessed different things. There's not a relationship. So ours is a case-based paper. It's not an OSCE. We have simulations, but Canada Physiotherapy does OSCEs. For us, it's too expensive. And it clearly shows that the assessments that are being done in clinical performance are assessing a different set of outcomes and readiness, different than what the exam is. And in fact, we also know that the students they could actually not complete their clinical education and pass the licensure exam, which is a frightening piece. They actually could sit for the exam before the last internship is complete because we had some exposure of the exam, and so we're limited the number of times, and they can pass that exam and still flunk their internship. And I think that's a caution, because to assume that licensure alone is assessing what is performance-based with patients in live is not the same as a paper exam. And the context piece, I want to speak to that, is very important. We have students who have split rotations. They'll do inpatient and outpatient, and they'll actually do fine on outpatient and do poorly on inpatient, where there's high morbidity, complex patients, caseload variability, interprofessional, whatever. And it shows that it is contextually based. They don't show the same problems. As patient caseload increases, many of the things that don't show appear in terms of what they're modulating. So we're learning more and more the licensure as an entity of itself, or the credential, is not sufficient to say in practice they are ready, because in fact they have had critical incidents in their final internship and still pass the boards. And for us, that's a red flag. You need them both. So it's possible they have to have both, and they can't graduate without the internship, so they could actually pass the boards and not graduate the program.
And I think just...
This is Eric. I just had a...
Go ahead, Eric.
Thank you. I would just add to that, I think there's a couple of really important points here. One is at least in medicine, certification is often equated with just passing the exam. And there certainly is evidence that, those who don't pass the exam tend, on average, not to do as well when you correlate their exam performance with clinical measures. But the amount of variance explained by that is relatively modest. The other piece around certification is that it's supposed to incorporate the other competencies that require other assessments, really getting at Jody's point. So in theory, the program director is supposed to sign off on the other competencies, and so certification is supposed to equal, competence in those other areas, plus passing exam equals certification. We know from research that many times those other areas don't get sufficient attention, and that people often come out insufficiently prepared in many of the other skills they need for successful practice. So I think that's a really important thing to keep in mind. And it gets back to the importance of really making sure the assessment system within a training program is very robust.
Thanks, Laura. You were going to make a comment.
I would only add that I think the complexities that you describe are even enhanced in nursing as opposed to our interprofessional colleagues by multiple layers of entry to practice. So when we enter at multiple degree levels, when our certification happens at multiple degree levels, that is pre-bac, post-bac, postmasters, but those complexities don't negate the need for us to tease out these models. They simply make the models more complex and are a cautionary note for us.
Linda Burns-Bolton, my question builds on this the discussion we just held, and would like you to comment on the role of ongoing periodic performance evaluation on credentialing. Just because you get a credential, is that the end? You're credentialed for life?
I can start if you wish. I would just note that there's pretty good research that on average, at least in the physician community, that you tend to see decline over time. The group that is most susceptible to that problem tends to be those in solo practice, for example, or small group practice. And so there's a nice review by Nitish Chowdhury from 2005 that really showed that there's a real concern around kind of a decay curve for folks. Certainly the American Board of Surgery has seen this as people come back. So there's kind of a recognition that there needs to be ongoing assessment. The question is, what is the best form of that? We also know that as individuals, we don't self-assess very well. And so it really needs to be informed self-assessment. And I think where the field is going is to make sure that that self-assessment is aligned with practice and ongoing. Current models tend to be very intermittent or sporadic and probably aren't very effective in helping physicians and others keep up because of their intermittent nature, and they tend to be relatively modest in scope. And so I think the big challenge moving forward is how do you embed it in daily practice? There are certainly mechanisms in some fields that do that very well. Registries would be a wonderful example of that. And some of the disciplines in medicine have very robust registries that allow ongoing feedback to not only the physicians, but the entire healthcare team. How are we doing with patients with cystic fibrosis? How are we doing with regards to angioplasty, et cetera? And I think we need to really think more about that for all healthcare providers, is how do we use that kind of ongoing clinical data to help all of us get better?
I was going to say the concept of continuing competence is elusive at best because everybody's professions have changed. And so as you're assessing people, you're assessing them against today's standard, not when they graduated. So just CEUs and maintenance of CEUs isn't enough. We're exploring our federation of licensure, portfolio opportunities, other types of things. Different for our residencies. Residencies have maintenance of certification, and there's a process they have to do, and they have to either retake or show certification in our board certification areas, not unlike medicine. One of the things that's happening is they're actually starting the process of trying to develop some standard assessments for like residencies coming out with a same set of competencies, no matter which one you go to, and they're going to build off of the CPI where it ends and take it through beyond entry level to mastery. So we're actually going to have a continuum of where you start at beginning level and all the way through if you do board certification. And that's the closest we're getting to actually having a lengthy continuum that will carry that through. So we'll see what happens.
But the development of such a continuum also sort of builds on something that Patty mentioned earlier today, and that is the notion that development of competence is not isolated to the educational experience or the practice experience, and that if we are able to identify those together, that there is greater likelihood that we can develop methods to assess them appropriately over those milestones in career development.
So we're out of time. Join me in thanking our speakers. On the agenda, we now have a 15-minute break, reconvene here at 3:30. Thank you.